Hi, everyone. Welcome to the Gut Reset Summit. I'm your host, Dr. John Dempster, and today I am joined by Dr. Mark Davis. Dr. Davis is a licensed naturopathic doctor in Maryland, the District of Columbia, Oregon, and California. He's on the board of directors of the Gastroenterology Association of Naturopathic Physicians and the editorial board of the Natural Medicine Journal. He's the chief scientific officer at Biome Bridge, which is an FMT bank in Panama City, Panama, and is also the chief scientific officer at Anthera, a VMT lab in Portland, Oregon. And Dr. Davis also teaches the gastroenterology course at Southwest College of Naturopathic Medicine. And he has focused on patients with IBD since 2016. And we're going to get into this all today. But you can also check out Dr. Davis at markdavisnd.net. But Dr. Mark, great to have you on the Gut Reset Summit. How are you today?
Fantastic. It's great to be here. Thanks for having me.
Well, thanks for squeezing us into your busy schedule with all those accolades. I know you've got a lot on your deck these days, but I also know, we're going to talk a lot about IBD and naturopathic medicine today and everything in between, but I know you've got a great story and I want to hear all about your experience with the microbiome. How did you get into all of this?
Okay, so that's my obsession, really, in terms of modalities. And I was a student. It was about 15 years ago when I started to work a lot with Dr. Steven Sandberg Lewis and work a lot with patients with inflammatory bowel disease. And we were doing everything in our naturopathic armamentarium to get these patients better. And often it helped. Diet and probiotics and herbs and supplements and lifestyle and all of those things. But there were patients who weren't getting better too, of course. And so I scoured PubMed to find whatever I could in terms of therapeutics that could help these people who were still sick. And I still remember where I was standing in the hallway at National University of Natural Medicine when I first found the papers on FMT, or fecal microbiota transplantation, which at the time was more commonly known as human probiotic infusions. And that's the process, for your listeners who don't know, of taking stool, feces from screened human donors and extracting or concentrating the bacterial portion of that stool and administering it to the GI tract of people who are very sick. This can be very helpful. In fact, it's almost a silver bullet for patients with antibiotic-resistant C. diff infections. That's a type of colitis that kills tens of thousands of North Americans every year. But it also can be very, very, very helpful for people with inflammatory bowel disease. I've used it for hundreds of patients with inflammatory bowel disease. They don't all get better, of course, nothing's magic, but with some many, many amazing results. And it can help people with neurodegenerative conditions and many different autoimmune conditions and other gastroenterological conditions. So what happens in the gut affects the rest of the body in many different ways. And that's when I became obsessed with the microbial medicine known as FMT. And then it's just recently that I've gotten into VMT. You mentioned I'm chief scientific officer at Anthera, which is a startup in Portland, Oregon. And there we're doing vaginal microbiota transplantation for women with drug-resistant bacterial vaginosis, or BV, and endometriosis and other things. So I also do have one other microbial medicine I'm obsessed with, which is there's tiny worm-like little organisms that live in the gut called helminths. They live in the guts of all kinds of mammals and vertebrates. And basically, they can modulate autoimmune and inflammatory disease in some ways too. So I've used those with dozens of patients with IBD, sometimes with amazing, amazing results as well. So those are the microbial medicines that are sort of bizarre and I'm sort of obsessed with.
I love that. I mean, you are, a man of many talents by the sounds of it. But this is going to set the stage perfectly for our talk today, because I want to hear, first of all, as a fellow ND, we have a lot to offer when it comes to inflammatory bowel disease. But I want to hear from you, your expertise and sort of where are we going right now with naturopathic medicine? Why is this a valuable tool to consider?
So one thing that I love about it, in the 5 pillars of naturopathic medicine, the one that is most unique to our profession is the vis medicatrix naturae, or harnessing the healing power of nature. And I think that this is the most raw aspect of the healing power of nature we can harness, when your medicine is literally alive at the time that you use it and can change the living makeup of the microbiome of your gut. We also talk about treating to cure, and not just palliating, but actually focusing on curative treatments, not just the symptoms. And this is something that FMT, or fecal microbiota transplantation, can accomplish with some of our IBD patients too. Because for some people, the root cause of their disease is microbial dysbiosis. And when you're able to correct that, they stop being inflamed.
Awesome. Yeah. And I know with your protocol, Dr. Mark, you've got sort of 5 key steps that you like to look at. Now, I know everyone who's listening today, the majority of these listeners right now are going to be a little bit more of the layman's and the patient side of things, but there are clinicians listening as well. Tell us about your approach, this 5-step process that we should be looking at when we're dealing with IBD.
Yeah, so I lecture about this to the naturopathic and functional and integrative medicine communities, and it's a paradigm intended at clinicians, but it can be really helpful for patients to think about too, if they're working with integrative clinicians or not, even if they're just working with conventional practitioners. And here's the 5 steps. Number 1 is make sure that they're safe, because there are times when our patients with IBD are so sick they need inpatient care and around-the-clock monitoring and intravenous corticosteroids and other things like that, just to make sure they are not at risk of dying. Or sometimes they need part of their intestines surgically removed on an emergency basis. And it's our job as clinicians to recognize when our patients aren't safe and they need our colleagues in conventional medicine to get inpatient care. So that is step number 1, make sure they're safe. Step number 2 is get them into clinical remission. And people laugh sometimes that that's only step 2 out of 5, where they think that should be at the end. Makes my patients symptom free. And actually, unfortunately, some clinicians, conventional and naturopathic and other clinicians, sometimes do stop there. But making sure our patients go from sick to symptom free is my step 2. We call that clinical remission. And the next step is called serologic remission. And that means doing all of the blood tests and stool tests that we need to verify that our patients don't have smoldering inflammation. Because I've had patients who are symptom-free for years and years and years, but they have elevated, these are before they come to see me, they work with other clinicians, and they have elevated inflammatory biomarkers, which are constantly increasing their risk for colon cancer and extraintestinal manifestations and other things. So even though they don't have GI symptoms, they have inflammation there. So that's my step 3, is make sure all of those inflammatory biomarkers normalize, that their blood tests and their stool tests look normal. I am in favor of treat the patient, not the lab, but you cannot neglect the lab in this particular type of case. Step 4 is what we call histologic remission. Histology is the study of tissues, and it's also called deep tissue healing or deep remission. And that's when your gastroenterologist does a colonoscopy and takes little biopsies of the tissue, sends them to the pathologist, and the pathologist says there is no sign of active inflammation. Maybe there's signs of damage from past inflammation, but the tissues are completely normal and not inflamed at all. And that's what we call deep remission. And then step 5 is just maintenance, where we're testing periodically to make sure those inflammatory biomarkers aren't coming up, and we're making sure we're feeding the microbiome and other things. So those are my 5 steps that it's really important for clinicians to know and can be a useful paradigm for patients too.
And I'm glad you mentioned that, because this is also going to be a tool that people can start to bring to their physicians and say, hey, look, this is what we're learning on this summit. These are some of the things we want to start to talk to you about with my care. And so, I appreciate you breaking it down that way. So let's dive into it. How do we achieve healing all 5 steps here?
Okay.
Where do we begin?
So the cool thing is, it is really, really individualized. So we talk about individualized medicine and the importance of that. And sometimes that's more true, and sometimes that's less true. And I would say in the case of inflammatory bowel disease, it's more true. And it's a matter of matching the person's state and situation using a few different frameworks. And framework number 1 is, which modalities are best? So I try to at least think about each of a number of helpful modalities when I'm treating patients with IBD. Every time I at least think about diet, I at least think about herbal medicine, I think about supplements, I think about pharmaceutical medicine, I think about microbial medicines like FMT and helminthic therapy and probiotics. So I'm thinking about all of those things and trying to pick and choose what in there is best suited for the patient. Another framework to think about is where the patient is at in their inflammatory story. Do they have ulcerative colitis or Crohn's, for example? These conditions are very similar in many, many ways, and their symptoms can sometimes be identical, but they're very different or even opposite in some ways. For example, if you have a patient with active ulcerative colitis who's a smoker, a tobacco smoker, and you have them quit cold turkey, they probably are going to flare up from quitting tobacco. Whereas an active smoker with active Crohn's disease, if you have them quit, they're much more likely to improve. Their inflammation will go down. So those are ways in which they react in opposite ways. Also, probiotics, large doses of lactobacillus and bifidobacterium probiotics often help people with ulcerative colitis. And usually they do not benefit people with Crohn's disease. So very similar in many ways, but some important differences to know. Is it ulcerative colitis or is it Crohn's? Or, like about 10% of cases, is it indeterminate colitis, where we can't quite make the diagnosis? Is their inflammatory level mild or moderate or severe? That definitely affects which is the best intervention for them. What's the pattern of their inflammation? Are they constantly inflamed, or are their inflammatory levels going up and down? What are their exact symptoms? People with Crohn's can have a lot of diarrhea, or they cannot have diarrhea and have normal stools, or they can even be constipated. And that's very uncommon for patients with Crohn's. Abdominal pain can be very severe, or it can be not severe. Urgency can be bad, where people have to literally run to the bathroom, or sometimes don't even make it to the bathroom. Or for some people, urgency isn't that bad. So we tailor what interventions we're using to the picture of somebody's inflammation. Where is it in the intestinal tract? Just in the rectum? Do we call it proctitis? Or all the way up in the small bowel, or for people with Crohn's? So all of these things are how we individualize it. And then what are we using? I don't know if you want me to launch into some of my favorite interventions now, or kind of save that for the end when there's other questions.
Yeah, let's dive into the interventions in a moment. I actually have some questions. I want to hear how you arrive at a diagnosis. Now, how are people, and of course, there's different levels of testing out there. We've got our allopathic testing, very important, scopes and imaging. But also from a functional medicine lens and a naturopathic perspective, what are you seeing as an effective way to actually get us the information that we need to treat a patient effectively?
Yeah. So in terms of making an absolute diagnosis, my criteria are the same as the conventional medicine criteria, which is to say, we're looking for elevated inflammatory markers. We're looking for positive results on IBD antibody panels, including p-ANCA and ASCA and some other ones. And then we're looking for positive histology, which means someone does colonoscopy, usually takes a biopsy and gives it to a pathologist who notices a particular type of inflammation that we associate with inflammatory bowel disease. Sometimes imaging like MRIs or CTs or something can be part of that diagnostic tree as well. So for my patients who come in and they don't have a diagnosis, but they're experiencing diarrhea, abdominal pain, that type of thing, I'm running those types of things. I'm running antibody panels, inflammatory markers, referring them to our colleagues in conventional gastroenterology for imaging and possibly colonoscopy. And then when they do have their diagnosis, another level of testing kicks in, where I want to know about their vitamin D levels. I want to look at IgG4 reactions and other food testing reactions to look for food sensitivities or inflammation brought on by certain foods. I'm looking at ESR and CRP and fecal calprotectin for inflammation usually. I'm running complete blood counts and comprehensive metabolic panels to make sure their liver's doing good and see what's going on with their red blood cells. Are they anemic? And their white blood cells and ratios between them. Sometimes I'm looking at SIBO testing for breath testing and other types of more obscure inflammatory markers. And then I like to repeat those inflammatory markers usually once a month, which is more than most docs do it. But for me, that is valuable course corrections about what we're doing is working or not, and how fast it's working. And do we need to bring on new interventions, or are things working so quickly we need to drop out some older interventions? So I use frequent testing once a month, occasionally more frequently, to really offer those valuable course corrections about what interventions we should be giving and how much.
Really, really important. I'm so glad you gave that list. For everyone who's listening, press pause, go and re-listen that last 2-minute segment. That's a list of markers that you can start to discuss with your primary care physician. If you haven't had those run and you're suspicious of IBD, That is a wonderful list. Dr. Mark, thank you for sharing that. I fully agree. Those are so important to look at. All right, so we've got a diagnosis. Let's say we've got, we found out whether we have Crohn's or colitis, and they're both equally important. Where do you begin from an intervention standpoint? Actually, you know what we'll start with? Out of all the interventions that are out there, what are not working right now? And that was something I also know that we wanted to discuss today. What are some of these therapies that we're hearing a lot about that you don't see are clinically relevant?
So it really depends on the individual. So I do see a lot of colleagues who give a lot of regular lactobacillus and bifidobacterium probiotics to patients with Crohn's. And I used to as well, before I did a brief literature review and found out that in pretty much every placebo-controlled trial of probiotics for people with Crohn's, the probiotic group is no different than the placebo group, or in one case, even substantially, significantly worse than the placebo. So since doing that literature review, I do not by default recommend probiotics, or at least lactobacillus and bifidobacterium probiotics to my patients with Crohn's. That being said, there are individuals who I am sure are benefiting. They come to me and they have a pattern of probiotic use and response that sends a clear message probiotics are helping them. And so for some individuals, it can help. But as a general rule, as a population, probiotics don't help. A lot of colleagues love to prescribe low-dose naltrexone. I also, in some cases, do like low-dose naltrexone. But I find that for people with severely active disease, or even moderate to severely active disease, I don't see LDN touch it, really. It's not going to make the difference. For people with mildly active disease, it can be really, really helpful. And for people in remission, it can really help them stay in remission. So that's another case where sometimes I see colleagues just throwing it out at everybody, and you've got to know the best patient to pick it for.
Awesome. Thank you. All right, let's get into the ones that are working that you're seeing. Where do you begin? Do you start with diet? Do you go straight into some prescriptions? How does it work for you?
Super depends on the patient. So, for example, just in terms of patient preference, I've had patients who say, if I can bring this into remission with only diet, I will follow everything you tell me to the letter. And they will change their diet in exactly every way that I recommend. And for many of those patients, they can bring their inflammatory bowel disease into complete remission with nothing but diet. Other patients, in my experience, say, I would like to do anything except diet. I hate changing my diet. I don't want to change it. That could be for emotional reasons, social reasons, religious reasons, financial reasons. Maybe they're not the one who does the main cooking in their household. For some people, changing diet is very hard. And so I say, great, well, there's a million ways to get you into remission, and we don't have to work with diet. So that's an example. Do I start with diet? That really depends on the patient and their preference. For patients who do want to do it with diet, there are also a number of ways to do it. So some of my patients say, look, I can deal without grains. Just don't try and take meat away from me. And for those patients, the specific carbohydrate diet or other sort of riffs on that diet, like the autoimmune paleo or other versions, that can be a great diet blueprint for them to start with. And then we further individualize it to them. Other patients say, look, I was vegetarian or vegan for a long time, or maybe I am now. That's my preference. I don't want a lot of meat in my diet. It's important for me to avoid that for whatever reasons, religious or emotional or political or financial or whatever. Mm-hmm. And for those patients, there's another blueprint developed by a Dr. Chiba in Japan, a gastroenterologist there. He's published extensively about this, and he calls it the semi-vegetarian diet. You still can have meat once a month, fish once a week, but there's a lot of things that specific carbohydrate diet forbids. Rice multiple times per day, miso soup, which is a fermented bean soup, every day. Very different diet. And if that type of diet is your preference, that's a great blueprint to start from. And they're both highly evidence-based. Great blueprint to start from. And then again, we individualize from there. Also, especially with my Crohn's patients, and especially if they're young and have ileal disease in the small intestine, for those patients, I love to use something called exclusive elemental diet, which means they're actually not eating any solid food for a period of a week or a week and a half or 2 weeks. Their only source of calories is this sort of gross tasting powder. I tell people it tastes like sickly sweet dishwater. And that's all that they do to consume calories. And that drops the bacterial load in their gut, gives their immune system a lot less to be angry about, and gives their immune system a time to calm down so you can use your other techniques to get things into control. So I love using exclusive elemental diet. I love using IgG4 testing and sometimes other testing to help guide what foods people should eat and include or exclude from their diet. So diet isn't for everybody, but for the people diet is a good choice for, we like to individualize it and nail it in. And you can see success with just diet, as you may have seen with your patients as well.
Oh yeah, and I'm so glad to hear that, you have some flexibility there, because I think that's also that's tough for people. Food is it's sensitive to them for many reasons, and it's a delicate topic to bring up, especially when you're making massive changes for somebody who doesn't feel well.
Yeah.
Right? And so it's one thing to know, hey, this is 100% going to work for you, but there is no 100% in medicine. We have to say, look, these are the probabilities, and sometimes those big dietary changes, they're not ready to do that. I'm really happy to hear that you've got flexibility there, because that's truly my philosophy as well. And so, okay, so we've got that sort of main dietary conversation. I also have a question on that for you.
Yeah.
The elemental diet also brings up a lot of anxiety for some patients. How do you circumnavigate that? Because that's an extreme way of eating. And how do you bring down their worries and their anxieties?
Well, it's not the right diet for everybody. And some people have so much anxiety that I say, let's just try a different route for now.
Mm-hmm.
But one thing that helps people to hear about it is temporary. We're not asking you to eat like this forever. We're asking you to do it for a week or 2 weeks. And then you hopefully can go back to eating the foods you love and not be so limited and so inflamed and sick and in pain. And so, you'll have this weird week or two where you're not eating solid foods, and then you go back to hopefully a better place. So that's kind of the spiel I give people.
Yeah, that's great. All right, so let's talk prescriptions. What are we doing from a naturopathic perspective?
Yeah, when I practiced primarily in Portland, Oregon, where there's a very broad prescriptive scope for naturopathic doctors, I was managing people's 5-ASA drugs, mesalamines, and managing their corticosteroids sometimes. And, that's okay. It wasn't my favorite. Now that I'm primarily in Maryland and doing telehealth in Oregon and California and DC, and we don't have prescriptive scope in Maryland, I've really backed away from that and made sure people have a gastroenterologist on board who can manage their prescriptive drugs. And I can help get them to a point where they hopefully no longer need some or all of those prescription drugs, but I'm not managing them myself. I do miss prescribing naltrexone for some patients. And I do fair amount of microbiome analysis, there's a couple kinds called 16S rRNA testing, or whole microbiome testing, or whole genome testing, or shotgun metagenomics. And that testing sometimes reveals things like fusobacterium in my ulcerative colitis patients. And in that case, especially if they're hard to control otherwise, sometimes we prescribe antibiotics to get rid of that fusobacterium. And it's a big course. It's doxycycline, amoxicillin, and tetracycline, all three of those at the same time. And so because that gets rid of the fusobacterium, but often can throw the rest of the microbiome a little akimbo, I like to follow that with fecal microbiota transplant for patients who are open to that and have it available to them. And I'll prescribe, my patients with C. diff on top of their IBD. That's another type of colon infection. I'll prescribe vancomycin for that. I'll prescribe rifaximin for my patients with IBD who also have small bowel overgrowth or other antibiotics sometimes. So sometimes they can be really helpful. They're not always necessary, but when they are, and I will say, biologics are expensive and have side effects and only work in a minority of people, but they can be lifesavers too. I'm so glad humans invented them and that we have them, because sometimes they're the right choice for people, and they do increase risk for other autoimmune conditions, but there's things we can do with naturopathic medicine to lower that risk. So I'm very glad that we have prescription drugs available, especially corticosteroids, which save lives. And then I can move on to supplements. Corticosteroids made me put me in mind of it, because whenever I prescribe prednisone or someone's a patient's other clinician prescribes prednisone, I prescribe DHEA, an equivalent milligram to milligram ratio. That's dehydroepiandrosterone, sort of the sister hormone to cortisol, and prednisone hits cortisol receptors. So cortisol and thereby prednisone drop inflammation, which is great for people who are super sick, but it also increases irritability, insomnia, mood swings, weight gain, fat redistribution into unusual places, and other side effects. And if you give it sister hormone, DHEA, you keep the anti-inflammatory benefit, but you really decrease that side effect profile in a way that benefits people's long-term health, prevents some of that bone density loss that you get with big, long courses of prednisone. So you get the benefit without so many of the side effects. So I love DHEA for that. I like to use melatonin and liquid multivitamins for our patients who have a lot of vitamin deficiencies. Vitamin E, I will use rectally. Colostrum, I'll use rectally. Vitamin D orally for patients who are deficient. N-acetylcysteine as an antioxidant and biofilm disruptor. The list goes on. And that's pretty individualized too, based on what a patient's antioxidant status is and vitamin D status and where in the body the inflammation is. Like I'll use rectal vitamin E oil, but only if they really have distal proctitis, inflammation right at the end of the digestive tract, right before the anus. So those are some of the supplements that I love, and the list goes on.
And I like how you mentioned DHEA because that also helps manage some of the crash that can happen when people are coming off of the prednisone. And, you know, it's one of the biggest things people are like, wow, I feel like Superman. And then I didn't. But yeah, you know, these things are all still meant to be managed. These are DHEA is a prescriptive hormone. You've got to take that with care. But in terms of antimicrobials, you listed a great number of some of the traditional sort of prescriptive agents. What about some of the botanical agents? Do you find any of those as effective? Do you find them less effective?
They can be equally or more. It really, again, I've said this so many times, but depends on the individual and their situation. There's an herb called Qing Dai or Indigo naturalis that I've written about and lectured about. Amazing herb from the Chinese medicinary. And that can be as effective or more effective than prednisone at getting very, very ill people into clinical remission and beyond. It has to be used carefully because used in large amounts for a long time, it can have real serious adverse side effects. So that is one of those very powerful, almost drug-like herbs where you have to use it with a lot of caution because it can provide great, great benefit, but also has risk for harm if used without enough caution and care. And I've used it in dozens and dozens of patients, and I've not seen any of those bad adverse effects, but they're out there in the literature. So that's an amazing herb. Wormwood, Artemisia absinthium, I love to pair with a green tea extract called EGCG. Those two work. People with moderately active inflammatory bowel disease, just that intervention can bring them into clinical remission. Sometimes that combo of wormwood and EGCG. Turmeric and its extract, curcumin, phenomenal for people with mildly active disease. Mastic and chamomile and calendula. There's different antimicrobial and anti-inflammatory herbs that are just perfect fits for different types of people.
Fantastic. Yeah, that's great. And it's really nice to know that we can integrate and bring things together. You know, it's not an us versus them. We're in this integrative, I think we're moving towards it closer and closer. I think we still have work to do, but you know, that's what I really love about functional medicine is it's bringing these two different languages, almost bringing them together bit by bit. And if you can have somebody like yourself who can navigate both of these languages, and that to me is going to provide IBD patients with the best options that are out there. I think that's really powerful. One thing that we've been doing in our clinic with our IBD patients is we've also been doing vitamin infusion therapy and intravenously. So we find that very helpful, especially when there's a lot of malabsorption and just raw irritated tissue. We find that can be very helpful.
Yeah, especially with Crohn's patients, if you have the area of the small intestine that absorbs certain vitamins very inflamed, you just cannot absorb those vitamins and you will get deficiencies. And so oral liquid multivitamins can help with that, but intravenous vitamin infusions can be, they can just really bring people's energy and mood and function up significantly in like just one treatment.
Absolutely. All right. So how are you monitoring? You know, I know you mentioned some of the labs. So that's great. You know, are you looking at any other signs, any other symptoms? What's the time frame? I'm throwing a lot at you, but you know, what if somebody comes to you and let's just pick on colitis here.
Yeah.
Somebody comes to you with really serious colitis, you've got it under control. What's their time frame to heal? Like, when can they start to say, hey, all right, I can start pulling back on a few of these things now?
Okay. So of course, varies hugely by the individual. But if somebody comes to me and I get through step one, where I say you are safe in outpatient care, you're not in such a dangerous situation that you need to be inpatient. How long does it take to get someone with severely active disease into moderately active disease? I would say 3 months is a reasonable period of time. Does it happen faster? Yes, I love it when it happens faster. Can it take longer? Absolutely. But I think 3 months is a reasonable period of time to get from severely active disease to moderately active disease. And then again, another 3 months to get from moderately active disease to mildly active disease. And then another 3 months from mildly active disease to complete clinical remission. And then sometimes people hit clinical remission, serologic remission, and histologic remission, my three benchmarks, all at the same time. And sometimes they move from one to the other to the other. And everyone's story is different. Some people get better, and then they have a little flare up, and you have to figure out what's going on and get that in control. And the shape of everyone's remission path is different. And of course, there's people that I don't ever get in remission. I'm not perfect at this by any means. But I think about 3 months, 3 months, 3 months from severe to moderate to mild to complete clinical remission is a pretty decent time range. And my newest project is trying to move to very, very carefully monitored IBD care. My new project is working with some residents that I trained at a project called IBD Solution at ibdsolution.com. And there we're actually using an email survey program that's HIPAA compliant to collect people's symptoms every day. And so that creates a chart. So we see them at our visits and we get the story of what's been going on, but we can check every day, what does the chart of their inflammation look like? And be able to see, are they getting better? Are they holding steady? Are they getting worse? Sometimes we call in extra. I've been using the system for about 2 years in a small way, and I'm trying to launch it in a big way with these residents. So looking at symptoms literally every day is my favorite way to really keep on track of these IBD patients. And then doing labs about once a month. So those are my best ways to really keep on top of it, are very regular symptom collection and labs.
Amazing. And are you finding right now, are you finding these outcomes are better than the conventional treatments that you're seeing that are just doing conventional? And
okay, so
I'm not putting you on the spot, Mark, but you gotta give it to me straight here.
Okay, so I think so. I think so. 12 years of clinical impressions is my results are substantially better than conventional medicine, even with hugely expensive biologics, et cetera. But humans are so good at making mistakes. And IBD is a naturally waxing and waning condition. So when we look at clinical trials of biologic drugs or of FMT or other things, in these 6-month trials, usually about 30% of people in the placebo groups are going from active disease to clinical remission. And so, or at least getting a clinical response. And so they were people we might have thought were being helped if they were in the treatment group, but they're not, because IBD naturally waxes and wanes. So I am always asking myself the question, am I just lucky and getting a bunch of people who are on the natural wane as we treat me, or as I treat them, as we're treating? Because humans are really good at making mistakes. So that's why I've been working with these other docs, colleagues, and former students to come up with this IBDsolution.com program where we're looking at symptoms every day and biomarkers every month to say, we ask people to enroll for a year to be able to say, is this just an impression that we have, or can our hard data that we're collecting over an extended period of time really demonstrate that what we think is true, that we do get substantially better outcomes than conventional medicine? So my answer is, I think so. I hope so. I can't say for sure that I know yet, but I hope to be testing that philosophy in 2024.
I think you're onto it. I'm obviously in the same space, so I've personally seen some astounding things clinically with our patients when they stick to these treatments. But I think you're right on that cutting edge, Dr. Mark. This is amazing. Thank you for sharing your pearls. And what I'd love, is there anything else that's out there that's outstanding that you'd love to drop on us today that can be very important and insightful from an IBD naturopathic connection?
Oh, there is so much. There's so much. I mean, my colleague Ilana Gurovich is a big mentor of mine. She's a leader in the field of naturopathic IBD care, and she likes to use a lot of rectal ozone insufflation. I've used that a bit myself. Pretty painful for people with active disease, but can take people, for very sick people, sometimes from a flare down to well-managed clinical remission pretty quickly. So I love seeing that happen. Vagal nerve stimulation. I know you're familiar with cranial nerve 10, which really connects the brain with the digestive tract and sends information directly to the brain through the digestive tract, from the digestive tract. And there actually have been clinical trials of, in the case of the trials, surgically implantable vagal nerve stimulators that can bring many people with Crohn's disease into clinical remission. So I've been trying to work with other ways to stimulate the vagus with my Crohn's patients with a little success so far, but I think we're going to be learning a lot more about that over the next 5-10 years. Other interesting, exciting probiotics besides our typical Lactobacillus bifidobacterium probiotics. I'm sure you're familiar with Saccharomyces boulardii. I've used that a lot. Also, E. coli Nissel, E. coli 1917 is a great one. Available in Canada, not available in the United States, but I've used it with my Canadian patients. Sometimes had American patients drive to Canada to get it. Clostridium butyricum, and some of the spore former probiotics. So there's other emerging probiotics that are not as well studied in the literature that I've been using with patients for, well, some of them for 5-10 years, and am starting to get a lot of experience with and interest in.
Well, that's amazing. I mean, when you think of the hundreds of trillions of bugs we have in our gut, I'm sure we're just at the nascent growth curve of some of these studies right now. But thank you for sharing. And obviously, you touched on the vagus nerve there. Stress is obviously a big component to most IBD cases, but something to consider as well. But Dr. Mark, this is amazing. One more time, where can we find you online?
So for IBD patients who are interested in intensive management and willing to do the work of collecting symptoms every day, getting labs once a month, we're enrolling at ibdsolution.com. And then if you're interested in knowing more about FMT and Panama City, Panama, I'm Chief Scientific Officer at biomebridge.com. And on my other microbiome work in Portland, and theravmt.com, where we're doing vaginal microbiota transplants. So, and you can just find more about me and read my writing at markdavisnd.net.
Awesome. Listen, Dr. Davis, thank you so much for being on the Gut Reset Summit. Thank you for all the work you're doing, and I look forward to collaborating more with you in the future.
Thank you, Dr. Dempster.
Take care.